in-house right now, that I can just filter out from the beginning. Any big major concerns about VADs or the equipment or anything to start with?
It's not the question, it's not about, there's one, on station 3, the man has a LVAD at the same time he's taking Novanox. Kind of worried that, we should not give the Novanox on the other side because of we Google it, they said there's nothing, but since you are coming, we're gonna ask you, can we give you Novanox?
Because Lovenox, we know how much it bruises your tummy and all that good stuff, and we like to rotate sites with injections. I say you can kind of rotate sites. I just say stay away from right of the exit site, kind of in that dressing area. You can kind of go around it and stuff if you need to, if they're on several days of it. So I don't find any harm of using, like, if it's exit sites on the right side, any harm of using the right side. Just don't, most of the time the dressing is big enough over that site. Just be careful that you don't get into that dressing site, so you can kind of move around as you want to for that Lovenox. Does that help? But yeah, you don't have to just stay on the one side. You can go on the other side. Just steer clear of the dressing area in the actual drive lanes. So.
And you can give it in the abdomen. Nowhere else, please.
Yeah, I always do Lovenox abdomen.
Some people are giving it somewhere else.
Huh?
I'll talk to you about it.
I'm aware.
So I brought a little clip, kind of quick reference guide for you guys. I laminated these. This is so if you have questions or say you haven't had an LVAD patient for quite some time. Yes, these numbers and stuff are specific to our program, but I think the concepts in here are pretty universal, whether it's a Brian patient or a UNMC patient or ours. But it's just kind of a quick little flip reference guide of, gosh, what do I need to do if I haven't taken care of an LVAD patient for a while? So first of all, for any of our patients, I have all my contact number on the first. I know at Station 3, Jess has our 24-hour hotline. So any VAD patient you take care of will have a 24-hour hotline for their VAD coordinator, their VAD team on call. So should you be overnight, you have any questions about them, there should be a 24-hour number. Our specific 24-hour number goes to our hospital operator at Nebraska Heart. You just ask to talk to the VAD team on call. So during the day, 7 to 3, it's myself. After that, it's our nurse practitioners that come to call for the hospital. So if you call after hours, which the majority of these sections will be in the evenings, and I'm not sure about over here, but if you call after hours, you'll be talking to one of our nurse practitioners. They may not know our patient as specific as I would if I were to answer that phone. I follow those patients day, night, all around the clock. So you may have to say, yes, I got an LVAD patient over here. He's a new implant, or he's here for whatever reason. You may have to be a little bit more specific when you call after hours, just because they're not aware of where I have my patients located at. So, but contact number is the best.
I'm gonna interrupt you for just one second. So all of our VAD patients, we keep the phone numbers the very first part when you open the chart. So they should all be straight in front of the chart if you ever need to know where to call.
And if you have questions about the equipment, I think your best resource is always that patient. I have found, and as I've gone through and taught at many different facilities, if you go in, maybe you get this education a day, and maybe you don't have a patient for another year or 2 years or 6 months, a long time down the line, and you kind of forget about the equipment because it is so unusual. I feel like if you go in with kind of an asking attitude to those patients and just say, be upfront and honest with them, just be like, hey, I've had some training, it's been a long time since I've had a patient, show me your equipment, show me how you make your connections. I will say all of my patients, and I can pretty much say I'm sure all of the other patients are more than willing to share that information with you and show you. They're all kind of proud of their equipment because it's what's saving their life, to be quite honest. And so if you go in with that willing attitude of just saying, I don't know this, I've had some training, but it's been a little bit, can you just show me once again how you make your connections or those sorts of things, and ask them, it gives them a little bit of sense of, I don't know, priority and accomplishment of I know what I'm doing with my equipment as well. So go in with that attitude. I will tell you, don't go in and start unplugging things if you're unsure, because the minute I've had, not at this facility, I've had a staff member go into a room, the patient just got transferred from the hospital to the rehab center, and first night, guy had to go to the bathroom in the middle of the night, right? And so they come in and it's, you kind of assume it's like an IV pump or something that you can just unplug that has this backup battery, and they come in and unplug them from the wall to go take them to the bathroom, and of course all these alarms go off, right? Do you think that patient had any trust in any of that staff moving forward? Day one, they're unplugging you from the wall. The number one thing that you should not do is unplug that patient? No. So yeah, if you're unsure, ask that patient. They're gonna be your best resource, or their family members that are around, the best resource for you. So don't be scared to ask them. And I train my patients to say, you know what, you may be the one and only VAD patient that any of your healthcare providers, any of your doctors or nurses, med assistants anybody has ever seen in their whole career, even if they've been in a career for 30, 40 years. And so I train my patients to know that they're their best resource and that they're kind of the biggest knowledge base for everybody. So they know that you may not be as comfortable with their equipment as they are. So with that being said, I did bring my pumps. So there's 2 different generations of pump. This is called the HeartMate 2, and this is the new device, the HeartMate 3. Not that it matters on how you take care of a patient of which pump they have in their chest, but I think this is just kind of more show and tell and kind of fun to see the differences of what's actually implanted in these guys' chests. And so each of the VADs, the cannulas here are implanted into their left ventricle, so it's put in through open heart surgery. So if you're getting a fresh patient after implant, you know, they'll have their sternal incisions, they'll be on sternal precautions, not able to use their arms to get out of bed and stuff for at least 6 weeks. So essentially, all those metal pieces are the internal portion, and then what you have externally is the drive line. So the drive line will come out of the right or the left lower quadrant of their abdomen. Typically, your HeartMate 3s will come out the left, our HeartMate 2s will come out the right. Again, not a big deal for the grand scheme of things of how you care for these patients and which device they have. Just knowing they have a device and they have some equipment attached to them is what's most important. So as you come up, you guys can play around with some of the pumps. It's always intriguing to me of what's on the inside that we don't see. So their drive line that comes out of their tummy, they will always have a sterile dressing on, always. And I'm pretty sure that's universal for all of our patients from any program. Our protocol is that they use Aquasil and Tegaderm over it. So you may see a little variety of dressings, especially if it's a patient that has had an implant a while ago. Sometimes we have to tweak dressings if they have some sensitivity to the adhesive. If it's summertime and they're sweating constantly and that opposite of that Tegaderm is sweating off, sometimes they'll have some gauze and tape. So I always say, do the dressing change that the patient comes in with, because that's what they're most comfortable. And again, if you have questions about how they do the dressing change, I would always ask that family member, that patient. They're gonna be able to help guide you as well. Or call your VAD coordinator for that specific patient. So, but it's applied in a sterile manner. When we take a shower, so these patients are showering, I do want to encourage them to shower, especially if they've been out a while. Some patients fall into old habits of not really caring for themselves, and so I always feel like if they come into rehab for some reason, it's kind of a reset opportunity to say, you know, infection is one of our #1 causes of having a complication from an LVAD, an infection from that driveline site. So of course, if they're not bathing properly, you guys have seen them all, you know how they are, they come in, they're filthy, haven't hit a shower for a couple weeks, some days, and sometimes the only time they really get some good personal hygiene is when they're in a facility to help care for them. So we keep the dressing on during shower time, and then you guys press and seal here, Jess, that you use, we just do Glad press and seal over that site. I kind of find it easier like that foam tape. You can use silk tape or whatever you have, but we use that foam tape. Do you guys have that here?
I think they use paper.
Paper tape, whatever it is, to kind of use that press and seal over that dressing site to kind of help. It's another layer of protection from the water as it goes off. Because again, bugs like warm, cold, or warm, dark, wet places to grow in. So anytime we can prevent that from getting wet or moist, we want to do that. So, and then you will see this. I brought an example of a shower bag. And you can tell the shower bag is different from any of their other bags because it's kind of this vinyl material, more water resistant. This is actually made by the company to help prevent water from like shedding away from the equipment. So what happens is that I'll put this on. So they'll wear it across their body in the shower like this. I put it on whatever side that their driveline side is coming out of, just because the cord from their tummy, their driveline to here is short. So if their driveline's over here, it's kind of complicated. Stretches that cord a little bit too much. And the more you stretch that cord and manipulate that cord, the more likely that area around that cord is going to open up. And again, another risk for infection. So when they're in the shower like this, I never want this hung up on the shower head or on a little hook in your shower or sitting next to them. Because if they would happen to stand up and fall, it's going to pull on that driveline site. And again, as soon as we disrupt that driveline site, A, you can cause damage. B, it's a big opportunity for infection of that area to kind of open up around that site and to get germs and bugs in there. So always attached to the patient. So when the patient goes down, their equipment is going down with them. Not that we want any of that to happen. But, so I'll show you how this bag kind of goes together. So a patient will be on batteries when you give them a shower. So, and we'll pass this around and you guys can see, but the 2 batteries on the inside. And that's what we don't do with patients as we're tossing. Can you delete that from the video, please? Anytime Anytime you see a red section on any of their zip-up bags, that is where the zippers don't go. So that's the place where their driveline sight will come out in that little crevice. So when you zip it up, the zipper won't have an opportunity to snag some of that plastic coating of their driveline sight. So batteries are in there. You can see how their pocket controller kind of tucks in there. And then tuck your cords in. So the whole point of the pocket controller is that you can still see the outside alarm. Should you be in the shower and should you have any alarms during their shower time, you can still see it. And then you would zip them up. And then this section, and if it's a brand new shower bag, this one fits a little more snug, but it kind of overlaps, and sometimes you have to wrestle it a little bit to get it touched. And then there's a clip on the side, and that's their shower bag. Any questions with showering and protecting their driveline side or their equipment, or any experiences that anybody wants to share? Have you guys all had the opportunity to get a patient in the shower or get ready for a bath or anything? And then also when you're done, make sure you tell your nurse when you're done, because they should have a dressing change after every shower. Even though the dressing may be dry, our policy is that we still want that dressing change. We just want to, again, make sure there's no moisture in there that's going to kind of fester and allow germs and stuff to grow. So we talked about the drive line being the external portion. The drive line will now plug into the pocket controller. So this would plug in right here. So you will see that I've got this one as well. There's two different colors of the controllers. Again, they do the exact same thing. This kind of off-white color is for the HeartMate 2. This kind of blackish color is for the HeartMate 3. So if you see patients come in, that's one way of determining which pump they are. Again, it doesn't really matter for your everyday care, but some people will be like, oh, that looks different than what I remember, and then you can kind of worry thinking that it might be a different device. But two pocket controllers, just different colors. They all function. All the buttons are the same on them. So essentially there's three buttons. The top button is a battery button. So when you're connected to power, whether it's two external batteries or where you're connected to the wall module, you can push that power button and it'll show you how many green bars of power that you have. So, and don't be fearful of these. If you're in there assessing your patient or you need to get some numbers or alarm is going off, you can't turn off the pump. You can't change the settings. You can't hurt the patient by pushing these buttons to get the data, okay? So again, if you're helping a patient get out of bed to the bathroom and suddenly alarm goes off, grab this controller and look at it. This is gonna be able to tell you so you know what help do I need to get or what do I need to take action. Is it just changing batteries? Is it going to grab a nurse? Is it calling your VAD team? What's going on? So battery button, there's a alarm silence, everybody's favorite button on here, because when it starts chirping at you and yelling, what's the first thing we always do is hit the alarm silence so we can actually think and not be distracted with the loud noises. And then this little circle button is the number for the nurses that'll come in and assess the patient. We record their numbers when we record their vital signs. And I'm not gonna go into what all the numbers are. There's flow, power, speed, and PI. Again, we record those every day. When the patients are at home, I tell them to record those numbers because we want to look for trends. We want to look for what's different from the day before, where do they normally lie. So as the nurses are in here and they're assessing, if you feel like one of those numbers seems a little off, talk to the patient. Say where your numbers normally lie at, and they'll know when you have something above or below where their trends normally are. That would warrant a phone call to your VAD team so we can treat that a little bit better. Again, you can push these numbers in combination, individually, 100 times. You're not gonna change it, you're not gonna shut it off, you're not gonna hurt the pump. So if you maybe had an alarm, say it started beeping by the time you got it all untucked from their fanny pack or their vest or their bag that they're wearing or their shower bag, and the alarm went away and you don't know what it was and you're like, well gosh, patient's fine. Was it a significant alarm? I don't know. You can push the alarm silence and the circle button at the same time. And in this little screen, it'll give you the last 6 alarms, and then it'll give you one at a time, and you can just keep paging that circle button, and it'll go through them. I will say sometimes it's not enough of alarm to actually register, so if it's just like a couple beeps and it stops, there's a date on there, so always look at that date. So don't call me and be like, oh, they got low flow alarms, and then I get on the phone, and I'm like, well, go look at them again, or I come out here, and then suddenly it was maybe from 6 months ago during their implant time, and that alarm that you heard didn't register. So if it's just not gonna register on here, it's probably nothing to worry about. So, any questions about the controller? So patients always gotta be connected to a source of power. Majority during the day, our patients are gonna be connected to 2 14-volt batteries. They will have a battery charger in their room. Have you guys all seen the charger, what it looks like? I think there's a picture on here. There's a picture on here. There is a charger. It holds 4 batteries. What I will tell you with the charger, that I see most often is that there's little gold terminals on these batteries. Those go down and towards the back. So when they're sitting in the charger and you're looking at the charger, you should see this, the white section on top. They don't really go in there any other way easily, but I've come in, I've had batteries upside down and backwards and reversed and all sorts of directions. And one, again, the patients are gonna look at you like, well, what are you doing? And maybe not have a whole lot of confidence in you, to be honest. Or two, they're not gonna have their batteries charged. So the worst case scenario is that you have all 4 batteries in, upside down or backwards, they're not charging, they need to go on portable battery, now you don't have power for them to go to therapy or rehab or meals or whatever. So they go in like this. These batteries are not charged, but also individual battery, you can push this little white button on here and it'll light up green bars of how much power they have. So in the charger, there's a little light by each one. And again, if you haven't taken care of one of these patients, while you have patients in your facilities down both hallways, just pop in. You don't necessarily have to talk to the patient, you can if you want to, but just pop in and look at their equipment just so you can familiarize yourself with it a little bit. But by each battery charging section, there's red, yellow, or a green light. If it's a green light, that means that battery is fully charged. If it's a yellow light, it means the battery is charging. If you ever see a red light on that battery charger, first of all, take the battery out. I wipe down these terminals with a little alcohol swab, put it back in. If that remains red, take that battery out of use and call your VAD team. Something had malfunctioned with that battery. We get that occasionally, maybe a handful of times in the last several years, but sometimes it's just a bad battery. So, but yeah, if you have all yellow lights, but the patient needs to go on portable power to go to rehab or something, there's a little number button by it. You can push it and it'll tell you how much power, how much charging it is. So it'll say like 90%. Well, that's good enough to go out and about. A set of batteries for the HeartMate 2 will last about 10 to 12 hours. On a HeartMate 3, the speeds are much lower, and so they will pretty much probably last majority of the day, probably about 14 to 16 hours patients will get on those batteries because their speeds aren't as fast. So I tell the patients, regardless of what pump they have, especially if they're a new patient that was just freshly implanted, to get into a routine of changing those batteries. So I say, wake up in the morning, put on a fresh set of batteries, go on with your day. At supper time, when you sit down and eat your dinner, everyone eats about the same time every day. Just change your batteries. I don't care if you're gonna be going to bed in 2 hours. I don't care if you're gonna be going out for the evening and not getting home till midnight. Just change them. There's no sense of, because by the minute they get off their routine, oh, suddenly we're gonna go out, and what if they have an accident, or what if they have to go to the hospital, or what if, they get stuck at a friend's house and they're having fun, and say they forget their backup batteries. So although I know that's not likely in here when they're here, I like to prep them for going home. So, hey, you're gonna go to dinner. Why don't we just change your batteries, go down to dinner, you're good for the rest of the evening until you're ready to go to bed. So, and then when they go to bed, there's 2 different styles of plug-in modules. What do your patients have now here, Jess? Do you know, do they have the old power module or they have the little mobile power unit?
The little one.
The little one?
Mm-hmm.
So there's an old version that's, probably about the size of an old VCR that plugs into the wall. Each of them have a 20-foot cable. There's a white cord and a black cord. The older one is kind of a Y cord. The newer one is fixed into like a little tiny square with a black and a white connection. What's important is that you connect black to black, white to white, and only disconnect one cord at a time, okay? Never disconnect both of these cords from power at the same time. And sometimes if you have more than one person getting a patient up or getting ready to go out and to get him out or up for therapy or something, you might be working at the same time, just be careful that you're communicating that you only disconnect one from the battery and then plug it into the cord or vice versa. Does that make sense? That's probably the most important. Should you accidentally disconnect both cords at the same time, there is a backup battery in these pocket controllers for 15 minutes. It's gonna hoot and holler an alarm at you. You're gonna get a lot of attention, but it's not gonna shut the pump off during that period of time. So, and I've done it myself. I mean, it happens. You're talking or someone's helping you and you're getting patients up and you're like, oh, gotta get everyone down to a meal or gotta get everyone off to therapy, and you got your sidekick helping you, and so we've all done it. It's just a mistake. Now, when I see that patient and I interrogate their device, I'm gonna see that they've had no external power. So I'm probably gonna create some questions and say, okay, who's on that shift, who's working that patient? I wanna know that it was just a human error and not a malfunction of these cords, because we could get cuts in these cords, we can get slits or damage to these wires, and a lot of times they'll come up as no external power and they're periodically short out and have these periods where the pump is potentially shutting off. If that's the case, and if we can't explain why those alarms happen, then that's gonna require a little more investigation on my part. So I don't mean to be like 21 questions with you guys, but if I do see that, I'm gonna ask to make sure, oh, not a big deal. It was an error, I know what we did it, not a big deal, I know their equipment is okay. So when you get their batteries out of their charger, just pull them out. They have battery clips, and once you guys come up, there's red arrows on each of the, and you just face those arrows towards each other. You guys will be able to see that, and you just slide your battery in. So now your battery's ready to connect to your charger. And then when you also come up, you'll see there's two kind of half circles in those connections. You want to complete the circle. So when you do it, it's a push, and you'll feel it kind of sink in there. It's a little bit of a push. It's not, it just doesn't naturally get sucked in. And then just tighten this down. This does not have to be cranked down. We don't want to strip out these things. Just finger tight, because the next person behind you will be like, man, somebody really cranked that down. And that's, or if the patient's trying to disconnect. Again, if the patients are here and they're new patients, I want you guys to encourage them to do their battery changes, even if you are really great at it and you're in a hurry. The more practice they get in a facility with professionals around them, the more comfortable they are gonna be with going home and doing those connections on themselves when they're all by themselves. So, pretty simple. Any questions about connecting those batteries or those cords? If they need to go to the bathroom, their night cord should be long enough to get them in their room to the restroom. I'm pretty sure, especially in your rooms, it should be perfect. But I don't, and even if they're not, I wanna encourage them to be on batteries during the day. I don't want them to get in the habit of, maybe we have those patients that don't like to leave their rooms and don't like to be social down at breakfast and lunch and dinner and kinda complain. We've all had those, we know those patients, right? I want you to encourage them to try to get into that routine, because I don't want them on the cable. One, it's a trip hazard for, first of all, if they're getting up back and forth to their bathroom, sometimes they're independent, in their room, but it's a trip hazard for them. Two, it's a lot of wear and tear on their equipment, so if they're going back and forth to the bathroom, on their cable from their nighttime monitor, underneath the door thresholds, those doors are wooden and they're sharp, so the more times those doors kind of close over them, it can kind of wear down the plastic coating on the outside of that, the cable. So again, it's just dragging around, it's dirty. I like to, when we put them on batteries, wipe down their cords, roll them up, and put them nicely on their little bedside stand, so we take care of their equipment. So when patients are up and about, there's probably a variety of ways that you guys have seen how patients wear their equipment. Some may wear, I have some patients that wear like a fanny pack. I've got some patients that have vests with inside pockets for their batteries. This is another a bag that patients can wear across their body. Of course, it all zips up here, and has this little pouch, and so you can see the pocket controller in there should they need it, and they just kind of wear it across their body. So again, ask the patient what device they brought with them to wear their equipment. You'll see a whole variety of things. But again, when patients are up, I don't want them, or sitting in the chair, I don't want them to just have the batteries sitting on their lap next to them, or tucked between the handrail or the lazy boy there. I want the equipment to be attached to them. Again, it's just good habits for moving forward, so that equipment, if they fall asleep, isn't gonna fall down and gonna get tugged or pulled on. Make sense? Any questions about any of the equipment that we use to secure the equipment to the patient? Best? Yes?
Not really a question, but there's a lady that actually makes like shirts for the LVAD patients that they
Kathy?
can tuck. Yeah, they
like the
can
vest?
tuck into their stuff so you can't see it.
Yeah,
So
exactly.
they might come in with
So
those
yeah, we have a
too.
lady in town, Kathy Rank, she makes vests and stuff, with vests that go over, and maybe there's someone else that makes shirts. One of the kind of popular items my patients are wearing now is a consolidated carry shirt, just from like shills, like cops wear to put their pistols or their guns. I've never don't wear pistols, it's not Andy Griffith, right? So their guns kind of underneath their armpits, it kind of tucks underneath there, so it's kind of like a spandex shirt. They tuck their batteries where the guns would normally go, and then they just put their regular clothing over it. So a lot of times you may not even notice that a patient has those batteries. The other thing I have some of my men wear are football pants, like the spandex football pants. They, are kind of long spandex shorts. They have slits on the side to put like football pads in, when you're practicing, but they would just slide their batteries here on the sides, kind of like our cargo nursing pants, put them on, put their regular shorts or dress pants over them, and then essentially, again, you don't see any of that equipment. So sometimes it may not be something as external of, a big bag or an external vest. They can kind of hide it nice, and that gives a lot of autonomy to those patients too, of not walking around like they're, a mechanical robot or something, and having everyone notice like, oh, look at all these cords you have hanging out from you. I have a son, he's 14, he can spot an LVAD from a mile away. I've trained him well. I'm like, Mom, is that one of your patients? I said, honey, just I mean, we were like in Cabo, we were like in the airport going to Cabo, and someone had, I think they actually had a life vest, but he thought it was the battery, and he's like, is that one of your patients? I said, no honey, I do not have patients in Cabo, and if I did, I would be living down here, because I would be a good nurse, right? So, but yeah, he can spot it from a mile away. I'm gonna touch base on blood pressure real quick. For those of you that take blood pressure, I have kind of a step-by-step guide. So again, a nice guide to pull out if you haven't taken care of a patient for a while. If you have any sorts of relationship with the patients that are here and they may or may not be friendly enough to come in and say, hey, let me just practice and see how it goes, you can try that. The biggest thing with blood pressure is that we take it with a Doppler, manual blood pressure cuff. Get your Doppler out, and I kind of hold it over the brachial artery right in the crack of the arm there, and listen for a sound. You may not hear a nice pulsatile whoosh, whoosh. It may just be a sound of blood flow, because these are continuous flow pumps. Hold the Doppler there, pump up your cuff. You know, I go about 110, 115-ish or so, and then slowly let that cuff down. We're only looking for one number, and we're only looking for the number of when you hear that sound come back. So as soon as you start hearing that sound or sound, that's going to be your mean arterial pressure, your MAPS. So our goals for our patients are about 70 to 90. Each program may be a little different for the variations. But again, ask those patients, where does your blood pressure normally lie? They're going to know. And then you'll know if it needs a warning phone call to their VAD team. So it's one of those things where sometimes if you're just learning how to take those pressures, or if you haven't done them for a while, you almost need 3 hands. Sometimes I'll ask the patient, I'm like, okay, here, hold this Doppler right here. Or sometimes they want to come out and hold it for you, because the minute I start pumping up a cuff over here, especially about a large cuff, it takes a little more oomph to get that large cuff pumped up. The next thing you know, I'm sliding all over here with my Doppler, and I'm like, tell me if I'm moving, because if I miss it, just find your location again with your cuff down and start over. So it's a little tricky, but I think once you've done it a handful of times, it gets easier as you go along. All my patients are going to be on blood thinners. They're going to be on Coumadin at the very least. So just kind of a reminder of our Coumadin policy. Again, I would say majority everybody's about the same unless they've had some bleeding or clotting with a goal INR of 2 to 3. So draw those INRs as directed by your VAD team, and then you guys are great about getting results and stuff faxed over to us. So I actually prefer to have my patients come here, because you guys are always, Jess is always Johnny on the spot with all my labs. So I appreciate everybody else that has partaking in that, because I will I shouldn't say anything about any of the facility, but I like them when they come to Lancaster. That's my first choice, even if they're in Omaha. I'm like, we should just come to Lincoln to rehab. You know, it's nice for them to be close to me. So, but again, just know these patients, and even if you're not drawing their blood, as you're maneuvering these patients around, I mean, if there's a fall on accident or they slip, we always have to be cognizant of knowing what bleeding ramifications can come from them. You know, if they hit their head, if they fall and biff a joint or something, and they could be bleeding in their joint. So just be careful to know that there's extra bleeding risk with those patients. GI bleeding, if you're helping them to and from the bathroom and suddenly they have really dark black tarry stools, that's something to report to your nurse and to your VAD team, because they could have GI bleed too. So.
And one thing we started here is everyone that's on an LVAD gets a humidifier in their room. Nosebleeds are really big. We also should ask for like AR gel for their nose, because that's the biggest bleeding.
Yep.
I think we send the most people out.
I was gonna say, I think you
nosebleeds.
guys, for some reason, you guys have a lot of nosebleeds here.
Yeah, so that's one thing we've implemented. So if you have
That's
one,
perfect.
make sure that they have those things in place for that.
That's great. And again, if you guys have been great with our nosebleeds, we do send a lot of nosebleeds to the same ER, unfortunately, but we can't pack them and try to get them to stop on their own. Sometimes they just need to go in and get packed. So yeah.
The recommendation, I'm sure that yours are accurate, but Physicians Lab still has for mechanical heart, like the different recommendations.
For the INR?
Yes.
Uh-huh.
And the first time I saw it, it was really disconcerting. Thank God we have Jess, because I was like, but
Sure.
When you're bridging somebody, when you're trying to get them, what is your preferred? Do you guys your preferred injection? Like, do you guys?
Lovenox, is that what you're asking?
Yeah.
Oh,
is it
yeah.
Lovenox
So,
that you
yeah,
guys
for
prefer?
our
Okay.
program, and I'm not sure about the other ones, is we use Lovenox. So, kind of a general guideline, and it says on here too, for an INR less than 1.8, we will Lovenox. Now, I will tell you, with the HeartMate 3 pump, some programs are slowly starting to change how aggressive they are with those lower INRs, just because right now, because of it has an intermittent pulsatility. Once every 3 seconds, you'll create an artificial pulse. Not enough to actually generate a radial pulse typically, but it has a little fluctuation of the speed going up and down. So I think over the long-term goal with HeartMate 3s, their hope is that they can decrease the thrombus rate Right now, the thrombus rate on these pumps, 2.5, 3 years out in research is less than 1%. So the long-term goal is that if we can decrease the risk of thrombus with how the pump works, that we won't have to be as aggressive and maybe we can have a lower threshold for INRs. So I know like when Dr. Donnelly was around, we love Dr. Donnelly, we miss him dearly. If I had a heart rate 3 that was sitting at 1.7, he might be a little more lenient, especially if I knew somebody bled really bad or had really bad reactions from Lovenox, that he'd be like, hey, let's just increase our Coumadin, give them a couple days. If they're not therapeutic in a couple days, then we can start it. But as a general rule, less than 1.8, unless they've had a previous bleed, then sometimes their INR goals are a little bit less. But we Lovenox them. And if they don't have any chronic kidney issues, we do 1 milligram per kilogram every 12 hours, twice a day. Occasionally, I'll have a patient that kind of has a creatinine clearance that's a little elevated, and I will do 1.5 milligrams per kilogram just once a day. That's kind of a rare circumstance, but that would be a very specific order that's written for that patient. So yeah.
If you get a low INR and it comes back with Lovenox, make sure you get it out of the e-kit. Don't wait for pharmacy. A lot of times what I see is somebody will try to wait for pharmacy to get here, but don't wait. Give it right away, because they're gonna need another dose soon.
Yeah, and they show you about 12 hours apart. So again, by the time you draw morning labs and get them back, and you get back to your VAD team, and they get back to you, if you know you have something really low, you can always just call us and give us a verbal and get an order right away to start it. If you don't have a standing order for that, but again, we talked about rotating sites. You just steering clear of that driveline site or that dressing area, which is fine. Everybody hates Lovenox. I wish there was something else that we could give these patients as short-term bridging for them, but it's not, and I guess it's better than developing a clot in this pump. And with these pumps spinning anywhere from, on the 3s, 5,500 RPMs a minute, and on the 2s, 9,000, 9,800 RPMs a minute, if there's a clot in there, it's gonna go straight to your brain and cause a stroke. So I tell the patients, I'm sorry, I know you hate getting a shot twice a day, especially Lovenox, but it's to keep you safe and to keep you protected from a long-term complications. So yes.
When they go home, do you try and give them like one of the home INR checkers?
For our program, I try to get that approved with their insurance. Most, if they're Medicare, it's typically not a problem. The one guideline that you have to meet with Medicare especially is they have to be on Coumadin for at least 90 days. Some patients have been on it for years, and so it's not a problem. Because again, I've got patients spread out across the whole state of Nebraska. Their closest, place to get a lab draw could be, 30, 40 miles one way. And so, and especially with these patients they just up and down and fluctuate a lot with their diet and with their other medications. I like to have them. Some centers I know, I don't think UNMC does home INR monitoring, but I check them a couple times a year with a venipuncture and a finger stick at the same time to make sure they're accurate. I've had some patients that their finger stick is not gonna be, will be a half point different than their venipuncture stick site. So if I can prove that they're accurate a few times a year, then I'll have them do home INR testing because it's more convenient for the patient. We do all this for quality of life with these patients. Our whole point of doing this major therapy is for them to go home and live a quality of life and not be in the hospital, not be tied down to doctors' offices and labs and running around like crazy. We want them to enjoy life, and with their heart failure prior to their VAD, these patients were stuck in either hospitals or they're stuck at home because they couldn't go anywhere without being extremely symptomatic and not feeling well. So for our program, we feel like it's a big quality of life just to be able to, test your blood sugar, test your INR, take your pills, do whatever it is you want to do with your day. There's very minimal daily maintenance with all of this once they get home. So, but yeah, good question. Any other questions? Any other thoughts? Any other thing that you think that I missed that you want to touch base on?
Just our own policy. So the travel bag,
Oh, yes.
anytime they leave their room, they have to take it. That includes to meals, therapy, appointments is a big deal. If you get stuck somewhere and the batteries die for whatever reason or malfunction, there's not a whole lot of time to be racing back and forth from the therapy gym to station 2 or wherever. So always make sure that they have that.
And it's a good thing to help kind of teach patients to say, okay, what do we need to take out of your room? Pretend like we're going to the grocery store instead of going down to the theater or to the therapy gym. Pretend like that's a trip outside their home. And it has spare batteries, a set of spare batteries that should be fully charged, and it has a backup controller. Every once in a while you may have a controller that gets an alarm that you can't deal with, or I've never had one just shut off for no reason, but we need to know they have a backup controller should there be any emergency. Also, the nice thing with that, in front of all my travel bags, I put all their alarm guides in there. So should you get an alarm about any of their equipment, you have all that stuff easily accessible. And again, some things may not seem, when you're just in the same facility of moving them around from department to department, as important. Remember, you're kind of reinforcing what we want these patients to be doing at home. You guys are a huge pillar of education of how are you gonna live your daily life, and this is kind of their last step to kind of have that monitored a little bit before these patients are sent out on their own at home, and we can create new habits, or we can reinforce that maybe some of their old habits were bad, and we need to look at what the best way of caring for them. And also, if you're talking about patients about leaving, or if they go on a little outing and stuff over a holiday from here, make sure they have their bag, but I always remind them, don't leave this in the car. If you're going to Walmart shopping, or you're going somewhere, don't leave it in the car for a couple reasons. One, you don't want extreme heat or extreme cold to have contact with these. It just wears down your battery life. You know, if these are blazing hot, especially with a 110-degree temperature we're supposed to be filling today, in that car, you know it's gonna be way hotter than that. And so should there be an emergency, you can't have overheated equipment. Two, if you're in Walmart or you're in a store and something goes wrong, well, nobody's gonna know, hey, like, do you guys remember where you parked? How many times do you walk out of the parking lot and be like, where the heck did I park at today? Cause you just instinctually go in, like, no one's gonna know where your car is at. No one's gonna know that you have emergency medical equipment in there. Also, I have a bag tag on here, so it has their 24-hour VAD hotline number. So if they're carrying this with them in the store and suddenly they fall over and they don't feel good, all their contact information to who they need to call is right here on the bag. So it's kind of another security measure. Some patients will wear medical bracelets and stuff as well, but if you're carrying a big bag like this and you see, you know, tags and stuff, one might say like, oh, that doesn't quite look like a purse. Oh, look, you're not supposed to perform chest compressions, or you should call me, or I'm on a blood thinner, or any of those important informations. Which brings me to the fact of chest compressions. If we have a patient that has a code or has a medical event here, and this has kind of changed over the years, and I will tell you specifically what our program teaches for Nebraska Heart, that if they are coding and their VAD is not alarming, which means they're getting adequate flow. So there's little arrows on top of here. It's two arrows kind of going in a circle. They will be green at all times. Should this be alarming at you, low flow, or anything else that is wrong with this, or you don't have those green arrows, then you should perform chest compressions. But if you're in a code situation, this is not screaming at you, it has the green arrows, we don't need to do chest compressions. And why? Because chest compressions is to restore that blood flow, right? And if this VAD is working, they're getting a minimum of 2.5 to 3 liters of flow in their pump. Anything less than 2.5 liters of flow, this would be alarming at you, and then you probably should supplement with chest compressions. You can shock them. A lot of them will have internal ICDs that will shock them already. You can give meds, obviously call 911, do all those things that you normally do for a code. But if this isn't alarming, don't do the chest compressions. Support their airway, get them, you know, comfortable, stabilized, whatever you need to do, monitor them. But if this is screaming and hollering, low flows, and it's not working for some reason, then we say the chest compressions. So, and again, typically, you know, when you're in a facility, someone will be getting on the phone with your VAD center, and other people will be doing what they need to be doing to manage that patient. So, very rare. If they have an arrhythmia, they may be talking fine to you. They may just have very light symptoms. They may, something doesn't feel right, and next thing you know, you hook them up and they're in a fast like VT, or had a patient in VF that is sitting there talking to me, and I'm like, wait a minute, because it's flowing. That pump is going to keep that blood flowing, which is keeping that oxygen to our brain during that time. So, what else? I know you guys are tired. I know you guys want to get back to work, go home. Yes.
Okay, so what if somebody needed an LVAD at the age of 50? What's the life expectancy for them?
So it's interesting, because when you talk about life expectancy, people say, how long am I going to live on this pump? And I'm going to say, I don't know. I'm going to say, in general, a lot of the research out there for destination therapy, which means they're not eligible for a heart transplant at the time. So at 50, I would say, could they be eligible for a heart transplant? Because our basic requirements are less than 70, BMI less than 35, and a non-smoker. So as 50-year-old, I would think it could be a bridge, but maybe they're too sick to wait for a heart transplant and they need something in the meantime. And so they'll get an LVAD and then they get listed for transplant, so they're at least stabilized until they wait those couple years. A lot of research for destination therapy, which means those patients are not eligible for transplant. They say about 3 to 5 years. You know, after about that 3-year mark, your percentage of life expectancy. But a lot of times the research will show that these pumps, especially the twos, are implanted in an older population of patients. So the answer is, I don't know how long you're gonna live. I will say that there's been a circuit of these pumps in the laboratory running for over 15 years without any problems. Of course, it's on a water circuit versus a blood circuit, so you don't have to worry about clotting and stuff. So, I think last year I was at a conference and the longest living patient, he was still alive and he was going on like 16 years and he was probably like mid-90s by that time. He got implanted during research trials early on, and I think he had a pump exchange somewhere down the line, but when I first started this, 4 or 5 years ago, we met that same gentleman, introduced to us in one of their slideshows, and he was like zip lining through a rainforest in the middle of like Brazil or something with his like bad equipment strapped to him. So it just, it matters. I've had, my youngest patient is 40 right now, my oldest patient is 82. So it's quite a range. And my 40-year-old is not a transplant candidate. So he's been on support for a couple years, but part of it, he's not a candidate, he wasn't at the time. Part of it is that he chose that he didn't want to transplant. So, and he's got some lifestyle issues right now that would preclude him from
I was gonna say, what's going on when you're 40 and your heart's.
Yeah.
So if somebody, just say, cause my mind wanders, I should say.
Yeah, no, that's great.
When you say somebody, like, they have to have, okay, so say somebody, they lost weight and their BMI went below 35. Could somebody be a previous smoker and quit smoking?
Absolutely,
And then
yep.
be candidate?
Exactly. So maybe you're not a candidate at the time for transplant, and so we have to put this in, and we put it in as destination therapy, but then say your circumstances change. I have one lady that lost 70-some pounds after her LVAD, so because she could exercise and she could feel good. We later sent her in and she ended up getting a heart transplant. Her particular case, she had bad kidneys before, so all the anti-rejection medications for the heart transplant knocked her kidneys out. She's on dialysis. She says, I'd much rather walk around with batteries than be on dialysis 3 days a week. So the gold standard for heart failure treatment is transplant. Unfortunately, we don't have all those hearts on the wall we can just pull down and say, oh, you're robust, you're ANIC, whatever. We don't have that access and availability. But really, we're looking at long-term outcomes. Survival rate 2 years after transplants, like right around 90%. Survival rate with a VAD after 2 years is like 88% right now. It's really approaching up there. And again, we look at the risk and the reward, or for some people that have some kidney, maybe those anti-rejection medications aren't good for them and they shouldn't tolerate them long-term and could cause some different troubles. So yeah, we've had smokers before where they're not eligible because you have to be at least 6 months nicotine-free. We've had people with substance abuse issues that, at the time they're not eligible, but because they made lifestyle modifications that they become eligible. So it's kind of a cool therapy, and I think especially with the new device of the HeartMate 3, we've seen some really great results of this, and I think we're gonna continue to see better results in the future, once we get a little long-term data. But great questions, it's really good, so, yes.
Is it rare then that they die after a year of getting it? Or is that, you're saying that it's 80%?
Yeah, it just depends.
90%
A lot
up to
of
2
times,
years.
a lot of my mortality rate isn't related to VAD-related issues.
Mm-hmm.
It's because maybe we're putting it in when they're 75 years old and they have some other, a lot of other comorbidities, uncontrolled diabetes or whatever it could be.
Mm-hmm.
A lot of my mortality issues are not related to the pump, unfortunately, because we see that. So, yeah, Sadie.
I would say probably, more patient specific to, really to everything VAD related. It's very
Mm-hmm.
patient specific.
Yeah.
Because, you can have somebody who gets 3 different pump exchanges because they're just really prone to pump thrombus. We just can't get their INRs controlled, but that's very patient specific. So
It's hard to make a generalized statement when these
Right.
patients come in at such, they're coming in with, most of my patients that I meet that I'm ready to put a pump in, probably have less than 6 months of life to live, if that. I've had probably patients that probably had less than 6 days to live had we not acted, and they come in super sick. And yes, their recovery is a lot longer, but I've had patients have really successful outcomes when they come in that sick. But you have to think if your body is that decompensated when you come in and that close to death, it's gonna take a while for that kidneys and those livers and all those other internal organs to kind of pick up and recover once they get that blood flow. And the patients that I, have a stroke, everyone automatically wants to relate to the fact that they have a pump. Oh, you have an LVAD and that's why you had a stroke, and that's just one of those terrible complications. And yes, it could be related, but I had a patient recently, he had a series of TIAs and strokes before he ever had his pump. He has some vascular issues, obviously, in his brain with the blood flow and his vessels that are a problem, and it's in, you know, his INR was therapeutic when he had his last stroke, and he was actually right in the perfect target range. And so they wanna say, oh yes, it's that darn LVAD that's causing that stroke, but some people are just predisposed to some of those issues that, it's easy to relate back to this, but if you look at their long medical history, they've had these issues all along and before they've ever been on, mental health therapies, so. Yes?
What if there's a power outage? and
Good
Your
question.
batteries are shot or
Good
not?
question, so, so majority of my patients at nighttime will be plugged into the wall outlet, right? So say that's when all of our thunderstorms and ice storms and all that happens, or whatever time of day it is, power goes out. So they will flip over to that backup battery in their controller, so the power goes out in the wall, they're gonna automatically flip over to this, but this is gonna be hooting and hollering saying, woo, 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 I don't have power. It's not that good of an alarm, it's not a woo, 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 it's really not. So, I wish I would have done it, all or something, but it's gonna wake them up, and so then that gives them 15 minutes of, time to go connect to their external power. They have 4 sets of these batteries, and you know, with them lasting an average of 10 to 12 hours on the HeartMate 2s and even longer on the HeartMate 3s, they have a good probably 48 hours plus of power with all their batteries charged. But should it be an extended, you know, major catastrophe, a tornado or something, I say go to your local hospital or your local fire station, plug into one of their generators. Some patients that live out in the countries will have their own generators at home to plug in their VAD equipment. A lot of vehicles these days have plugins in their like trucks, like especially will have them. So some patients will use that as a backup. But I always watch the storm screen. I know exactly where all my patients are at, and I'll be like, "How's your power situation out there?" You know, and they'll be like, "Oh, we're good." But you know, occasionally we have a surge every once in a while. But it will alarm you. You have that backup power for emergencies, and then you just go to portable power. But yeah, great question.
So are the CNAs allowed to change the batteries here?
Yeah.
Okay.
And
As
so
long as, what I say is I like, before a CNA goes in and changes it, I would like a nurse to be in with them first, to make sure that they're able to do it. It's scary when the alarms go off, even I've done them for a lot of years, and it freaks me out when they start going off. So I would just make sure so that they don't get flustered the first time. I prefer a nurse to go in.
Perfect.
If a nurse feels like they're okay with it, then I'm perfectly fine with it.
So if they're
Sadie can
plugged
speak
in
her so she
to a
can-
battery and you just need to change their battery, say it's supper time, we just need to change the battery, you don't always have to do this connection, you can just push this button, pull out the battery, grab a new one from the charger, and pop the next one back in. Really, the only time you have to do these connections is when you're going to and from the nighttime modules, so.
And we change batteries at 2 here. Everyone knows 5 o'clock supper time's the busiest, so that's why we do it at 2. So if you have a patient, especially you guys have the long-term patient, but on station 3, they might say, no, I'm not ready yet, but we just explain why we do it at that time. If they're confident, they've been doing it a while, I'm fine with that. But for our benefit, really, because 5 o'clock is the busiest around here,
Just
or meal times in general.
reinforcing for them to have a set schedule of doing it, because the longer they get out from being on VAD therapy, the more kind of lackadaisy they are, and they'll be like, I think it was in like March, I had like 4 patients all call me and they're like, I forgot my travel bag and I'm away from my house and my batteries are beeping, what do I do? And I'm like, you drive like crazy, you drive mad crazy, right? You have 15 minutes of power left, you hit the pedal to the metal, but be safe. So, and people will ask me like, what if my batteries run out all the way, like my backup battery and everything, and I warn them that you're gonna be getting more alarms as soon as you flip over your backup battery, but what happens if all my power's out? And the answer, kind of like similar answer is, I don't know. Because these patients, most of them electively walked in to have this procedure done, and their heart, even though it was only ejecting at maybe 10% of what it should have been ejecting at, they were still up and moving and alive. They may have not felt very well. So if the power goes out, you're gonna go back to whatever ejection fraction or heart function that you had prior to your LVAD. Some patients get very used to having that flow to their brain. I've had patients where we've disconnected and they've just passed out immediately because their body got so used to them having that flow that as soon as they go back to nothing, they don't tolerate it. I've had patients that's been disconnected for 63 minutes at home because she takes some medication that makes her confused and she disconnects herself and she passes out, but plug her back in, hello, I'm back. So, I mean, the reality is that you don't know. And some people, even being on VAD therapy for a while, may have a little bit of myocardial recovery where their heart gets a little bit stronger because it's been supported. So maybe if they would run out of battery, they would actually feel okay as well too. So the reality is, I don't know. Let's not figure it out. Let's be in good habits of taking our emergency equipments and being on a schedule, changing our batteries. So, but any other questions? scared of the equipment, or are you like, I got this, bring them?
I'm scared. No, I'm just
I love your honesty.
Because,
Something too,
because in
you know.
my mind is like, okay, what happens if, you know, like, let's say, you know, he had a stroke and he peed like over a mouth and it gets on the side, like, do you automatically go get your nurse and change it right away before like infection or because
Yeah, I mean, obviously if they're soiled or something and,
Right.
you know, take care of the patient first, you know, get them dried up and cleaned if obviously nothing's alarming. But I mean, they're gonna have sweat and stuff, and so like liquids around that area isn't a big deal, but yes, as soon as we get that site and that dressing cleaned, if they do get soiled and stuff, then we can get it freshened up and a sterile dressing change and stuff. It happens, I mean, whether, it happens. Like, we know how it is, especially when they're in, they can't move around, so, but yes, I think just being aware of some of those complications that potentially could happen is providing great care. You know, like that's good because you're actually thinking like, I wanna make sure that his equipment is safe, and if he's on batteries and he's laying in a pile of urine, that liquid's not gonna get into those connections, or anything, so no, those are all really great thoughts, so.
do you put a pillow underneath them? Like you get the pad and then do you put the pillow underneath them or is it just, they just lay it?
If they're just jumping in bed for like a little snooze or just to kick their feet up for a little bit, I would just typically, sometimes they'll keep it in their vest if they wanna keep it in their vest or whatever, however they're wearing it. Some people like just lay the batteries right next to them in bed, so, but if they're at high risk for maybe having an accident or soiling something, I'd probably be a little bit more protective of that, you know, we can tuck them under. I don't really want this controller to get tucked under a lot of pillows and stuff, cause if you feel these controllers, they get kind of warm anyways, and then if they're tucked under sheets and pillows, they even get more warm. I've never had it like not work or get overheated to not work, but sometimes it can get a little bit warm, especially if patients are, you know, have some fluid on board or their skin is a little sensitive. I've never had it burn a patient, but they can get a little bit warm, and so I always like to have like a sheet or something between like their skin and their controller just in case, but I wouldn't intentionally tuck it under a pillow, but you can prop it on a pillow or something if you think they're at high risk for being soiled or having some sort of accident, so.
Dressing changes with the sterile dressing changes, everyone in the room has to wear a mask. We do get some patients that think because they're at home, they don't wear a mask anymore. In this facility, everyone wears a mask. So that means you put something on the door, nobody comes in, patient wears a mask, everyone wears a mask with the dressing change.
Very good, thank you for bringing that up, and again, it's a good way to kind of reinforce the right behaviors at home if they're not doing it. And blame me, say, you know, Kelly, she's a witch, I don't wanna call her and tell her that I'm not doing this right, or have you tattle on me, so, I put him in bad detention, I was like, you going to bad detention, I do not like that, so, put him in bad timeout, we giggle about it, but, and I was like, okay, yeah, we know, so, but yes, you had a question.
What's the probability of the driveline like pulling out?
Well, it won't pull out because it's attached to your pump, so if this, now if it gets tugged on and it gets loosened up, because Dr. Dalmy would put him through the rectus muscle and then out to the side, it's not gonna just pull out, because this is all sewn into the heart, that would have to be something very
So like
dramatic.
if it gets pulled out like too much or, you know,
It's
I mean,
pretty
is that
much,
a problem?
It's pretty much secured with, the length is kind of measured on the inside, so there's not a lot of extra space on the inside, and then over time, especially on this one, cause this is the part that's actually in, it has kind of a felt on there, and so your scar tissue kind of builds around that and kind of builds it up, and when we want to take them out, oftentimes it's very difficult. So we had a patient that got exchanged up at UNMC, and they left his old drive line in, they just cut it because it was too difficult to tear up his rectus muscle and stuff to get out, so. Some people you'll see have a little bit of fluctuation, they'll be like, oh my gosh, I think it's popping out, I mean, I'm talking like centimeters, and they'll be like, oh, it's pulling out, but the likelihood of it coming out, anything significant is pretty rare, because by the time we go down and over and kind of measure that area, there's not a lot of extra, and you'll see the HeartMate 3 will have, I think there's a little bit longer drive line, also you'll see on the outside of the HeartMate 3, it's a modular drive line, so should there get any damage to this section of the drive line, you wouldn't be doing it here, but we can disconnect and reconnect a new piece of the drive line. Instead of, that doesn't have that option on the HeartMate 2, they have to fly a company in, and it's like a MacGyver of stripping down those wires and, I say duct taping, but they do something fancier than that, so. But we can't repair a drive line externally if it's, one of these wires that get damaged. And if it's far enough away from that site, so, but. Alright, well, thank you all for coming here. If you guys wanna come up, put your hands on any of the equipment, do any of those connections, I welcome that.